A very good morning to all. So, today we'll be giving you an overview of autoimmune hepatitis in children as a clinical guide round from the Department of Pediatric Hepatology. I'll be the opening batsman for this, and so we'll go through several sections starting from epidemiology, diagnosis, how do you evaluate such cases, go through the management, the treatment withdrawal, the outcomes, as well as some special scenarios in autoimmune hepatitis. So, starting from epidemiology, if you look at overall the clinical presentation, all the studies have tried to define the clinical presentation in different terms. For example, if you say acute hepatitis, chronic hepatitis, acute liver failure or silent cases, some have defined that even if they have recurrent episodes of jaundice and still have clinical evidence of cirrhosis, they will still call it acute hepatitic kind presentation. So, the definitions are varying, but if you look at overall East versus West, predominant presentation in the Western literature is acute presentation, acute hepatitis kind of presentation, but in our settings is predominantly a prolonged history lasting over years and years altogether as a chronic presentation. So, if you look at all the major series that have come up in the world, starting from King's, from the last series, that's from ILBS, age of presentation, the female predominance remains the same, but the difference comes here that in Western literature predominantly it is the acute presentation, but in our settings it is almost majority of them will present with underlying cirrhosis. The proportion of type 1 versus type 2 remains same. Type 2 is more common in children, I will show this later also, and there is a significant personal and family history of extrahepatic autoimmune disorders. And though the percentage of cirrhosis, when they look at histologically, is still high, that was the oldest data almost 25 years back, 60% in King's, and slightly higher proportion of cirrhosis in Indian series. If you look at the two major series from pediatrics in children, overall the proportion remains the same from SGPGI and ILBS, except that there is a slightly higher preponderance that we published many years back of 23% of seronegative versus a slightly lower preponderance of seronegative autoimmune hepatitis, which gradually came down when they started re-evaluating or redoing these serological markers. But if you look at, say, adults versus children, so what is the difference? As I already mentioned that type 2, that is your LKM1 or LC1 positive AIH, it is predominantly seen in children, not in adults, it's less common. The proportion of chronic hepatitic like presentation or chronic presentation remains the same. Cirrhosis is slightly more commonly seen in children, and the antibody titers are higher in adults. So, that is why if you look at pediatric guidelines, even as low as titer of 1:20 for ANA asthma or LKM1 less than 1:10, we still take it positive. But these titers will not be considered significant in a patient who is an adult. So, we looked at our data courtesy Dr. Aditya, Saurabh and Anmol over last 15 years or so of autoimmune hepatitis, and we had almost 232 cases over this period. 17% had some kind of overlap. Predominant presentation was cirrhosis, 49 plus 33, and 18% were acute presentations. When we compared these three groups, the results were as we expected, that ALF would have a younger age of presentation, they would have the autoimmune hemolysis would be predominantly seen in the chronic or recurrent hepatitis kind of presentation. Platelets would be lower in cirrhosis, bilirubin will be higher in acute presentations, AST will be higher, AST-ALT will be, enzymes will be higher in the acute presentations, albumin will be lower, INR would be higher in the chronic presentation. So, no major surprises here. Also, one important aspect is, I have already mentioned in the first slide that extrahepatic autoimmune disorders are very, very common in autoimmune adults as well as children, but you need to look for it. So, if you see the common presentations, the most common presentation are skin related, thyroid, IBDs, autoimmune hemolytic anemia and celiac disease. So, if you are missing out on celiac disease, if you do not do a TTG, in serum TTG in these cases, and you do not start them on gluten-free diet if they are having a concomitant celiac disease, you are missing out on an option of using lesser immunosuppression or a better outcomes. IBD is most commonly seen with overlap cases, and the most common ones are thyroid and celiac. Never miss out on these. In our series, almost 1/3 of our cases had a concomitant autoimmune disorders, predominantly being vitiligo-like changes, hypothyroidism, celiac disease. And celiac disease, but presence of a concomitant extrahepatic autoimmune disorder was not associated with severity or outcome except celiac disease. So, do not miss screening for at least thyroidism, hypothyroidism and celiac disease in all such cases, because they may alter your management and outcome. So, how do you diagnostically evaluate such cases? We all know it is all about autoantibodies and IgG along with liver biopsy. Type 1 is ANA asthma and type 2 is LKM and LC1. SLA is predominantly not differentiating into type 1 versus type 2, but it is a marker for disease activity and prognostication. In our data, almost 232 cases, this is recent updated, there is a higher proportion of seronegative, but these seronegative are those ones in which we have proven on the basis of biopsy, and we have shown that after you give immunosuppression, these patients, majority of these patients improve. They come out of their cirrhosis, they come out of their decompensation. And
sorry,
yes.
Vikrant, can you go to the previous slide?
Yes, sir.
You say IgG is elevated in what percentage?
Sir, in our cases, only 95% they had elevated IgG in our case, but literature says that IgG may be normal in 15% and 25% of type 2, especially those who are presenting with acute severe presentations.
Next slide.
Yes. So, our IgG was elevated in 95% of our cases.
Okay.
Another important concept is seronegative AIH. We have a very high proportion of seronegative AIH. So, but these we diagnosed them based on histology and response to standard immunosuppression. And we do not believe of repeating autoantibody profile except from other centers that they are using, because they say that if you have a higher proportion of seronegativity at baseline, if you keep on repeating them after 1 year, 2 years or 3 years, majority of them will turn up to have some autoantibody later in the future, but we do not believe, we as a department protocol, we do it at the baseline and only follow them up with respect to their improvement in liver functions. So, when we analyze our data, seronegative versus seropositive, there was no difference between the histological activity, the clinical presentation, but seronegative patients had a lesser fibrosis stage on biopsy, and there was also no difference between type 1 and type 2 with respect to histology, lab presentation or the clinical presentations. So, there are 3 basic scores that are prescribed, I would say. The 1999, the original criteria, the simplified 2008 criteria, and this is the criteria that was given by our European Society, Pediatric Society in 2018. But predominantly, everybody uses the simplified criteria to begin with, but the original criteria is pretty good in our settings also, if the patient is presenting with acute liver failure or acute severe presentations, and it is proposed that the ESPGHAN criteria is actually helpful for those who are presenting with a overlap kind of presentation. But there are only a few studies, one were our study only which had proved this in 2018, and there are only 2 more studies which have proven this fact, but these 2018 criteria still remain under validated as of now. So, and if you look at our diagnostic scoring, almost some of these cases had a simplified score of less than 6, but all of these patients had fulfilled the original 1999 criteria and they had shown response to immunosuppression. So, Ashray and Vikrant did this study that was published in JPG, and they looked at what is the fallacy of using autoantibodies or IgG in CLD cases. So, they compared genetically proven Wilson's disease with autoimmune hepatitis. So, if you see, almost 83% of Wilson's disease had IgG of more than 1.1 times upper limit of normal, which is the cutoff which is used in simplified autoimmune criteria. And almost 32% had at least one autoantibody positive. If you compare these two, the only thing which would help you differentiate Wilson's and autoimmune was the histology. Nothing else could differentiate, because if, as expected, if you have a higher interface of plasma cell infiltration in autoimmune versus steatosis, glycogen nuclei in this. Otherwise, and except the type 2 AIH markers, LKM, LC1, which were higher or more significantly seen in autoimmune hepatitis, everything could not differentiate. No lab parameters, no IgG levels, the higher proportion of IgG levels, or overall antibody positivity. So this is always a fallacy, and almost 20% of autoimmune hepatitis Wilson's disease cases could fulfill the simplified criteria, and almost 8% had definite AIH criteria that they could fulfill, despite being genetically proven Wilson's disease. So in isolation, if you find a higher IgG, ANA positive or asthma positive, don't just label them as autoimmune hepatitis. You have to be very, very careful. And this is a radar plot in which you can see that the bluish one is the inside one is Wilson's and the red one is AIH. In immunological markers, the higher IgG was seen in autoimmune hepatitis, but if you see histological parameter, the plasma cell infiltration and interface hepatitis was more commonly seen in autoimmune hepatitis versus ballooning degeneration, steatosis, or glycogenated nuclei was seen in Wilson's disease, as expected. I'll request Dr. Rajiv sir to continue the second part of the grand round.
Good morning. So I will start with the histology of pediatric autoimmune hepatitis. So these were the statements which were published in the consensus which was generated last year and published in Hepatology International, that lymphoplasmacytic infiltration and interface hepatitis is the hallmark of autoimmune hepatitis. But in the setting of acute presentation, there may be other features like centrilobular necroinflammation, central perivenulitis, that is around the hepatic venules, and there may be massive hepatic necrosis or sometimes lymphoid aggregates, which may be seen with acute presentation like ALF or ACLF like presentation. Ductal injury may be seen, and studies have shown that the bile duct injury may be seen in up to 20-30% of the cases, but that does not indicate that this is all are overlap. Only severe biliary changes, if they are there, like bile duct loss or peribiliary fibrosis, so these are only suggestive of autoimmune sclerosing cholangitis or autoimmune overlap. So liver biopsy is essential, but in the setting of acute presentation, it may be avoided, or a transjugular liver biopsy may be done. So this is the data which was collected by Aditya, Anmol and Saurabh and presented by Aditya at APASL this year. So if we can see here, the commonest histological parameters are lymphoplasmacytic infiltrate, interface hepatitis, as well as ductal reaction. So ductal reaction we can see here are seen in up to 70 to 80% of the autoimmune cases.
Are Aditya, Anmol and Saurabh here?
Yes, sir. Aditya and Saurabh are here.
Can we see them?
So we divided the presentations as acute, decompensated chronic liver disease and compensated chronic liver disease. So they were almost, the presentations, the histological features were similar, but the crux of the histology was in acute presentation there was more of multi-accent necrosis and central perivenulitis, which was more common, whereas in compensated CLD there was less of ductal reaction and less of central perivenulitis. So these are some of the pictures which we got from Dr. Archana ma'am, and these were published in Hepatology International. So in the panel A we can see lymphoplasmacytic infiltrate. In panel B we can see ballooning as well as pseudorosettes. In panel C we can see here central perivenulitis. The panel D is of a child with autoimmune acute liver failure with multi-accent necrosis. Panel E with cirrhosis, with frank obvious cirrhosis, and panel F with ductal reaction, which is also commonly seen in children with autoimmune liver disease. So this is the box plot where when we looked up their histological activity index, so it is obvious that with acute presentation there is more of histological activity, HAI was high, whereas in the decompensated chronic liver disease the fibrosis stage was more. So coming to the diagnostic algorithm, so we cannot depend on only one criteria, either IgG, autoantibodies or liver biopsy. So we should depend on a combination of elevated IgG, positive antibodies and histology, and this should be supplemented by the simplified score. Like we can see here, with normal IgG and autoantibodies negative, if the suspicion is very high, we should go for liver biopsy and look for non-conventional antibodies If the patient is still seronegative, then depend on the liver biopsy findings. If they are suggestive, so then make a diagnosis of autoimmune. So now these middle two are again again there may be either elevated IgG or antibody positivity, but other feature is if it is not there, again we have to depend on the liver biopsy findings and look for plasmacytic, lymphoplasmacytic infiltrate, interface hepatitis, or make a diagnosis of overlap if there are severe biliary changes present. And in the setting of acute presentation, we should depend on the other histological features. So coming to management of pediatric autoimmune hepatitis, so before starting treatment, we should screen for tuberculosis, especially in the Indian setting. So based on either history, chest X-ray, Montaux, and look for the metabolic and bone health. Thiopurine methyltransferase activity, so this will be presented in detail by Bikran. So this is not essential because the proportion of TPMT deficient children is less than 0.5%. So it is the testing for TPMT is not cost effective. Whereas Nudix hydroxylase, which is again an enzyme which degrades this 6-thioguanine. So there is risk of cytopenia if Nudix hydroxylase is deficient, and prevalence of Nudix hydroxylase deficiency is high in the Asian setting, in the Indian IBD patients. So, but this needs more data in the setting of acute autoimmune hepatitis. So this is the standard management protocol. Children and adolescents with autoimmune hepatitis, so they are started on prednisolone at the rate of 2 mg per kg per day, maximum dose of 60 mg, which is gradually tapered to 0.05 to 0.1 mg per kg per day over 8 to 12 weeks. Azathioprine is started, so this is our departmental protocol, and this was published in Hepatology International also, that most of the centers now start azathioprine at the beginning only. So azathioprine we also start in all of our children, 1 mg per kg per day, which is increased to 1.5 to 2 mg per kg per day over 2 to 4 weeks. And we see reduction of AST/ALT. If it is more than 50% reduction, bilirubin and iron are improving. Continue with the same treatment, monitor CBC, LFT and IgG at routine intervals, and label as biochemical remission when there is complete normalization of AST/ALT and IgG, and continue with the same treatment. But on the other hand, if there is no response, there is no reduction by 50% of AST/ALT, or if there is worsening bilirubin or INR, or if there is treatment intolerance in the form of cytopenias, we have to switch to alternate immunosuppression. Then other scenario is of to look for the azathioprine response. So in terms of 6-thioguanine, 6-MMP and TG levels, and a surrogate marker is mean corpuscular volume of RBCs. So what azathioprine does is it suppresses it, so it acts at the DNA level. So it inhibits the proliferation. So the size of the RBC increases. So mean corpuscular volume, when you give azathioprine and if it is going beyond 93 or 96 femtoliter, so then that is a surrogate that the 6-thioguanine levels will also be high, and there should be response in the hepatic activity. So this is a study which was published long time back, where prednisolone was compared with budesonide. So budesonide has also been shown in adult studies also that the response rates are almost similar. So but there was an issue whether the prednisolone arm did not receive a proper tapering schedule. So whether it was early tapered or prolonged tapering was done, and also the proportion of patients with autoimmune overlap, they were also not clearly defined. So on the right hand side, there is another study on azathioprine monotherapy. So where again azathioprine monotherapy is not indicated for induction. So we have to use a combination of steroids along with azathioprine. So these are some of the statements which were published in our consensus. The same thing what I already mentioned about the dosing of steroids as well as azathioprine. So coming to azathioprine metabolism. So this will be now, I will ask Bikran to present some of the slides related to this aspect as well as withdrawal.
Thank you, sir. So this was actually, Dr. Seema ma'am was supposed to take this, but she's unwell. So I have a wee bit of idea on therapeutic drug monitoring of azathioprine and withdrawal. So I'd be covering these two parts right now. So if you see the drug metabolism of azathioprine, azathioprine is a prodrug which is converted to 6-mercaptopurine. Now this 6-mercaptopurine can go 3 ways. it can get methylated to form 6-methyl-mercaptopurine. It can go through this HGPRT pathway to form 6-TGN. Now 6-TGN is the active metabolite which is required for achieving immunosuppression. And third, it can go towards this xanthine oxidase enzyme and convert into 6-thiouric acid. So what we want a lot of this 6-TGN because that is what we want immunosuppression. But this comes with a caveat that if you increase the 6-TGN levels, it is also bone marrow suppression drug. So if there is a lot of 6-TGN, there would be a lot of bone marrow suppression. Now consider the scenarios. If there is a lot of TPMT, if there is a TPMT deficiency, we keep hearing about TPMT deficiency a lot. If there is TPMT deficiency, this pathway is blocked. Now let me take this as a red color. So if there is TPMT deficiency, this pathway is blocked. Now if you block this pathway, you are pushing the drug more into this pathway which is 6-TGN. Now that will lead to higher amounts of 6-TGN, which is good because there will be good immunosuppression. But it will lead to a lot of bone marrow suppression due to high quantity of TGN, which is not desirable. But fortunately, TPMT deficiency is very uncommon in India. In all the studies which have been shown, even in worldwide, it is uncommon. Only 5% patients have polymorphism in TPMT. In India, it is less than 1 to 2%. Now let's come to the second enzyme. These three metabolites are formed. Now this active metabolite 6-TGN is degraded by this enzyme NUDT, Nudrix hydrolase. This is NUDT deficiency. Again, this excessive accumulation of 6-TGN will happen. Again, a lot of bone marrow suppression will happen. So bone marrow suppression can happen due to TPMT deficiency. It can happen due to NUDT deficiency. And now there is a third scenario which is actually common in our clinical practice, which we may not realize, but if you go back and start seeing your patients, you will realize that there is something called hypermethylators. That is, these patients actually have a lot of methylation activity. The drug 6-MP will start getting converted into 6-MMP. So if you actually do the drug level, you will find that 6-MMP level would be very high, 6-TGN levels would not be achieved because the drug is preferentially being metabolized into by methylator pathway rather than HGPRT pathway. So what would happen? You would be not achieving the required doses and the patient will not improve. The autoimmune hepatitis, the enzymes will not improve and he will have a lot of MMP, which is hepatotoxic. So this is hepatotoxic metabolite and this is bone marrow toxic metabolite. Now let me show you this on a few clinical cases that we have. So this girl, Nancy, was diagnosed, presented to us with decompensated CLD in September 2025, was started with Visolone and azathioprine was introduced later on, and this is the OPD paper around I think 5 to 6 months after her first presentation. You can see here, this is the paper in February 26. You can see here that the bilirubin has normalized, but the enzymes were persistently high. Now, this was at the time point where MCV was 99 or 100. MCV is a surrogate marker. If I go back here to this slide, now I told 6-TGN is a bone marrow suppression drug. So if a drug is causing bone marrow suppression, MC will rise. So that is how we currently estimate that 6-TGN levels have been adequately achieved or not. So if you see this, this was the time point where allopurinol was added. But unfortunately, if you see here what happens, you add allopurinol, patient's AST/ALT improves, but see her bone marrow. The hemoglobin goes down from 14 to 13 to 11 and to 7.8. The TLC goes down from 11 to 7 to 4 and 20% of this is polymorph. That means ANC is less than 1000. Platelet has gone down a wee bit from 217 to 132, but is not in the range of thrombocytopenia. So here we get the levels done. Now see the levels here. 6-TGN levels is 642, which is more than what is required for the child. 6-MMP level is 780, which is kind of normal, and the ratio of MMP to TGN is quite low. That means what actually happens with TPMT deficiency, that we have artificially created by adding allopurinol, because allopurinol blocks this pathway, it blocks this pathway and pushes the drug into 6-TGN pathway. So you'll get more of 6-TGN by adding allopurinol, but at a cost that there can be risk of bone marrow separation. That is what happened in this patient. So we realized this and we did a bone marrow, there was bone marrow separation, and thereafter we stopped allopurinol and we are waiting it out. This was stopped, I think, 2 to 3 weeks back. The hemoglobin has improved a bit and we are waiting it out to see the effect. The next point would be to decrease the dose of azathioprine. Now, coming to the second case, again this case, around 17-year-old child who type 1 autoimmune hepatitis, who presented with acute hepatitis in 2023 and was being treated on prednisolone and azathioprine, and 6 months back allopurinol was added, possibly because IgG was persistently very high in this child, although AST, LT were in the range of around 40s, in the range of 40s. So again you can see the AST, LT completely normalized after adding allopurinol, but in this patient, the patient has not yet developed cytopenias, but if you see the report of the levels, you can see that 6-TGN has shot up very high, 6-MMP is very low. So on the basis of this report, we can think of two things. One, the patient is having TPMT deficiency, that's why the 6-MMP level is low and 6-TG is very high. Or the second, again the allopurinol has acted to behave like TPMT deficiency, artificially creating a kind of TPMT deficiency. So again, this patient, allopurinol we have stopped. We did the TPMT genotyping. TPMT came out to be normal in this child. And this was also apparent because the patient was already receiving immunosuppression for last 3 years. So if the patient had TPMT deficiency, he should have developed bone marrow separation. He could have developed bone marrow separation by now. So this is how therapeutic drug monitoring can help you differentiate between azathioprine overdosing, azathioprine underdosing, TPMT deficiency, NUDT deficiency, and identify the hypermethylators who are actually needing allopurinol and avoiding unnecessary allopurinol just on the basis of MCV, which is a very crude way that we were following till now. Coming to the second part, withdrawal of immunosuppression. This is normal, we'll just continue with, we'll minimize the doses of immunosuppression.
How
that
do
will
you
be the
know
way.
it is, what was the starting AST, LT in this patient?
Sir, you mean at the time of starting allopurinol?
Yeah. No, starting of the immunosuppression.
Oh, that was around more than 1,000. So this was acute hepatitis presentation. It was like, I'm not very sure because these are slides were made by Dr. Seema ma'am, but it was more than 1,000, 1,500.
Patient?
Even this patient was a DCLD.
What was the starting AST, ALT?
Starting AST, ALT is not written here, sir. This is 4 to 5 months later, but it was, I think.
We all monitor with AST,
yes, sir,
or ALT coming down, but I don't see they are very high. So how do you monitor your pediatric autoimmune, with IgG or AST, ALT?
With both with AST, ALT and with IgG, sir.
Okay.
So yes.
All right.
So obviously there are differences between there are differences in different I am not a very keen believer of normalizing IgG, but obviously most of the pediatric hepatologists believe that and the guidelines says that IgG should be normalized, but I differ here from others on that point. I'll come when I come to it, withdrawal of immunosuppression. So withdrawal of immunosuppression, relapse rates after withdrawal of immunosuppression has been seen in adults from ranging from 25%, and there are some studies say even up to as high as 89%. But if you go to pediatric studies, it shows that after stopping immunosuppression in AIH, the relapse rates range between 50%, between 12.5% to 50%, and the relapse rates are higher in those who have unsupervised withdrawal, that is, they stop treatment by themselves. If you see the predictors, younger age at withdrawal of immunosuppression, shorter relapse-free duration, that is, after the patient has achieved remission, the shorter period when you start withdrawing. ALT more than 0.5 times the upper limit of normal, that is, patients who have like borderline 40 ALT may have higher risk of relapse after stopping immunosuppression, and against what is expected that type 2 will have more of relapse. This has not been shown in any study till now, any pediatric studies till now, that type 2 will have more relapse rates than type 1 AIH. Some studies have shown that extrahepatic autoimmune disease will have higher rates of relapse, but there are contradictory studies which show that if patient is having associated celiac disease, there would be actually less risk of relapse after stopping immunosuppression, which is difficult to explain. Now, I'll just show quickly the two cases. First case is 15-year-old child relapsing jaundice, not decompensated with a type 1 autoimmune hepatitis, HAI-12, no fibrosis. This child was treated with prednisolone and azathioprine, went into remission within 2 to 3 months, remained in remission for 2 to 3 years, and liver biopsy showed histological remission. Immunosuppression was stopped, and this slide is old again, 2024. So 6 years follow-up, the child continues to be in remission. Case 2, 4-year-old child, decompensated CLD with very high IgG to begin with, again type 1 AIH, but with significant fibrosis. Again treated, went into remission very quickly within like a month or so. Histological remission was proven, fibrosis had regressed to F1, HAI had reduced to 1, immunosuppression was stopped, but relapsed after 12 months with HAI of 6 and F1, and again immunosuppression was restarted and the child went into remission again. So currently it is very difficult to assess the factors which patient we should stop immunosuppression. So Aurab is working on that, and we should have our data very soon. I'll be showing a part of data, but exact data we'll have soon, because we have not had many relapse, so we cannot compare. We do not have comparable groups right now. So, but if you compare the case 1 and case 2, one thing is apparent, that decompensated CLD patients have a higher risk of relapse. That is from the literature, and that was what's seen in our case. Very high IgG at the time of initiation of treatment and high IgG at the time of stopping treatment have been described in literature as risk of relapse, and cirrhosis at the time of starting treatment or at the time of stopping immunosuppression withdrawal have also been identified as risk factors for relapse. Our child had F3 fibrosis at starting treatment, but only F1 fibrosis at the time of stopping treatment. So this is the protocol that is been recommended in the guidelines, pediatric guidelines that we proposed, although I will say that again that I don't agree with a lot of this. So complete biochemical response is something that is a must, and which is defined as AST, ALT and IgG below upper limit of normal for 24 months. I don't agree with the IgG part here, but this is how the complete expert group agreed, that AST, ALT and IgG should normalize for 24 months. Then liver biopsy should be done, and HAI, the activity should not be there in the liver biopsy. Now this is again a very questionable point. When do you do a liver biopsy? When the patient is on immunosuppression, you do a liver biopsy, patient is in histological remission, you stop. But that histology actually reflects the status when the patient was on treatment. We don't know how the patient will behave off treatment. Should the liver biopsy be done after tapering off the steroid or stopping the steroid and azathioprine, or should we do two biopsies? One at the time you start tapering and one you stop when you stop the drug. That is questionable. But the guidelines suggest that before starting the tapering, you should do a liver biopsy. Consent is a must. Because if the patient is not following up, you know that 25% risk of relapse. So if the patient is not following up, and this is what happened with one of our patients recently, we stopped treatment around 2 years back when she was 16 and a half or 17 years old. She was from Assam, I think, Sikkim. So the patient went back. She was following up with us in online OPDs, but then she was lost to follow up with us also after like 3 to 4 months. And she came back to us. Obviously was admitted in adult side because now she has become more than 18 years, but she came back with ALF presentation after having relapse of autoimmune hepatitis. So consent for withdrawal is a must, because the patient must get the LFTs at designated time point. Right now what we do, once we have histological remission, we withdraw therapy by gradually tapering the steroids. Steroids is already tapered, gradually tapering the other drugs and stopping the steroids. And we follow this pattern monthly. We do the AST-ALT weekly for first 4 weeks, and then monthly for first year, 3 monthly for the second year, and 6 monthly from third year onwards. So this is the ILBS data on treatment withdrawal. This is again old data, 2024. 146 patients who had completed 3 years follow-up on treatment, of which 29 patients were in biochemical remission for more than 2 years after achieving biochemical remission. Liver biopsy could be done in 23 of them, of which all of them had histological remission on liver biopsy. These 23 patients, we had supervised treatment withdrawal. Another 4 patients, when they got to know that they were on biochemical remission, did not undergo biopsy and stopped the treatment by themselves. Now, if we follow these 27 patients with treatment withdrawal, we have this follow-up for now almost 33 months plus 2 years. So that is close to 5 years follow-up, median 5 years follow-up. And relapse rate is written as 3 here. Currently, the relapse rate is 4 after adding the ALF, which came back last month. So 4 out of, I think it's 31 or 33 right now. So it is more than 10%, around 14-15% is the relapse rate in our treatment withdrawal of AIH in our data. Thank you.
Quickly go through the DTT or the difficult to treat AIH group. So there are 3 definitions which guidelines use. One is treatment intolerance. That means you are starting a drug, but adverse effects are preventing the continuation or escalation. The second one is incomplete response. That means even after a good amount of dose and duration, you are still not able to achieve the remission. And third one is the severe one, that is treatment failure or no response. That means either the patient is worsening with respect to coagulopathy, increasing bilirubin levels, or you are not able to achieve at least a 50% of decline in transaminases levels within 4 weeks. ILBS data, this is courtesy Saurabh. We almost 33 out of our 140 cases who are on actually good number of good follow-up, that is 21% is the proportion of our difficult to treat AIH group. And if you see, the predominant presentation is still cirrhosis, some of them are ALF and ACLF also. This is a handmade diagram by Saurabh, sometimes difficult to see, and there are a lot of arrows going here and there. So what has happened that our protocol of DTT-AIH is that we start on second line therapy, which is mycophenolate mofetil. Some of the cases, if they are hypocellular marrow, are also started on tacrolimus. And the summary of this is, even if you start a second line or third line therapy, the response is roughly in the range of 30 to 50% at every stage. So if it is not responding to AZA, almost only 20 to 30% will respond to MF. And if they are not responding to AZA and MMF, if you start tacrolimus, you see the remission rate is between 30 to 50% at every stage. Another important concept for published by Samanne's thesis with the help of Dr. Shwetank and Dr. Ashi, the gut microbiota comparison between difficult to treat and easy to treat. You look at this axis 1, this is principal coordinate analysis. You see there is a significant difference in the beta diversity. What is the exact difference in the phyla? That in the difficult to treat group, the bacterodata were more abundant and actinobacteria were less abundant. If you look at the genus level, the difficult to treat group had lesser bifidobacterium, but long-term data and validation from other studies is missing, and we still do not know how do you use this data to clinically alter the course in these cases. So what is the long-term data? Everybody has been talking about how good these patients if they are started treatment at the right time. So look at this study that was published from Italy and France, the largest data in the world, over 35 years of follow-up. And this data shows that if you start treatment, their outcomes, even if they are cirrhotic at baseline, are at par with the liver transplant data. 30-year survival, native liver survival is 61%. That is the best data outcome that you can achieve, even in the long term, if you look at even the liver transplant centers also. 10-year survival, native liver survival is 88%. And also this was published from King's. Almost if you see the 20-year survival outcome, native liver survival is 74%. And so, which patients will achieve this kind of outcomes? If they have lesser amount of cirrhosis at baseline, if they are responders to treatment, if they do not relapse, or if they do not have overlap syndromes. And as Vikrant had already mentioned, relapses can be seen in almost 20 to 60% of these cases. So pediatric AIH, you may have sustained remission, you may have incomplete or non-achievement of remission. If you may have cirrhosis at baseline, you may continue to have persistent cirrhosis, go on to develop decompensation, or you may have cirrhosis reversal. And as already mentioned earlier, if you do not respond to the treatment which is given to you, obviously you will have a poor outcome. If you have a significant histological activity or showing biopsy showing necrosis, you have frequent relapses, that is how you identify these likely non-responders. So in our series, we had followed up these 232 cases. Out of these, almost 146 had survival with native liver. and almost 33 had either death or had got liver transplanted. If you look at the comparison between the survival and the death and liver transplantation, the results are expected, because if you look at difficult to treat, those who were difficult to treat had poor outcomes. Those who had higher bilirubin had poor outcome. Those who had a higher INR had poor outcome after they were initiated on treatment. And otherwise, presence of multi-acidic necrosis, presence of cholestasis, and absence of pseudo-rosetting were predictors of poor outcome. If you look at the multivariate analysis, patients who were presenting with acute presentation had 4 times odds. Every 1 unit increase in INR increased the risk of mortality by 64%. Presence of cholestasis had 2.5 times odds ratio of poor outcome, and pseudo-rosetting was protective at biopsy. Another important concept is recompensation. That means you started with a decompensated liver disease, you start treatment, patients start recompensating, and this was a concept which was given by Baveno. You need to suppress the primary etiology, you need to ensure that you show that there is no ascites, no HE, no bleed over a 12-month period, that is the consolidation period. So this we published almost 2018 with help of Dr. Archana ma'am. We had a few cases of autoimmune hepatitis where we'd had a sequential biopsy after we had started treatment, in which you can see even patients who had baseline fibrosis of 6 or incomplete nodules or complete nodules 5 and 6, after treatment, after 2 to 3 years of follow-up, you can see that there is regression of fibrosis from 6 to 4, 5 to 1, 6 to 4, 6 to 2, 5 to 3. That means even if you start, these are, majority of them are decompensated CLDs who came out of their recompensation, we did a biopsy, cirrhosis regressed. And this was beautifully shown by Archana ma'am's slides. You can see breaking down of those thick septa, the collagen proportionate area went down. So this was almost 10-year-old data. And Anmol's thesis work had shown that the recompensation rates, once they come out of their initial 1 month of period in which if they are dying or if they are undergoing transplantation, over the years AIH had shown a 70% recompensation rate as they progress further. And the predictors of recompensation, the only independent predictor was that portal hypertension, that means USG spleen size, but these were smaller numbers, we cannot go much into the detail. And we have shown this earlier also, radar plot in stool cytokines and plasma cytokines. IL-10, if it is higher in the stool, it is an anti-inflammatory marker, was higher in the recompensated group, and also IL-1 beta, though is a pro-inflammatory marker, it is a surprising finding. In plasma cytokines, if IL-6 was higher, lesser in the recompensated group. So IL-6 and IL-10 are, IL-1 beta and IL-6 are the typical pro-inflammatory markers. So if they are lesser, so it is good and patient will recompensate. I'll request Rajiv sir to take up the special scenarios.
So on special scenarios, so first one is overlap. So we know that overlap is diagnosed when there are both features of hepatitic activity as well as biliary changes, or either on biopsy or on MRCP when there are classified as either small duct changes or large duct changes. So it is mentioned that the revised IAIG criteria 1999 and simplified scores can miss up to 50% of these overlap children. And ASPGAN score, as already Vikrant mentioned, that ASPGAN score, when it is used, because it takes into account the cholangiographic findings. So this may be helpful for diagnosing autoimmune sclerosing cholangitis. So there is a data, the long-term study from Birmingham, where they mentioned that around 26% of autoimmune hepatitis ultimately either have a overlap at presentation or in the follow-up they may develop. So half of the patients developed sequentially. They had hepatitic presentation and then over time they developed overlap, and 2/3 of these progress to typical primary sclerosing cholangitis changes along with development of IBD. So this is the concept that hepatitic activity can progress to develop biliary inflammation, like they have ductal changes, biliary inflammation, periductal reaction, or even periductal fibrosis, and over time they may progress to develop primary sclerosing cholangitis. So this is a concept which was proposed in a review article by Dr. Benita Kamath. So what about the data? So this is the data from King's as well as from other centers from Brazil, that ASC overlap is present in up to 2 to 21% at presentation. And this is our ILBS data. Around 34 of our patients had overlap, 24 with large duct involvement on MRCP, and 5 of these patients who were followed up over time developed overlap features in the form of cholangiographic findings over course of time. So next coming to acute presentation. So severe acute presentation have been defined in adults up to 3 to 33% and around 7 to 21% of the children. But there are certain diagnostic difficulties with ALF or ACLF presentation. They may have normal IgG, they may be seronegative, simplified score may not fit in, percutaneous liver biopsy may not be feasible, and typical histological features, as I already mentioned, may not be present. So there is a single meta-analysis of 61 studies in children, so where even with acute presentation, there was 60% survival with natal liver, and this was related to a combination of steroids and other immunosuppression. But the predictors of response when you give immunosuppression, they are not clearly defined. So this has been proposed that steroids should be given in the ALF or ACLF setting under careful vigilance in the presence of, but in the presence of advanced encephalopathy, or if there is lack of response to steroid within 7 days, they should be subjected to liver transplantation. So this is the data which was collected by Samanna and which is still under review in JPGN. So 48 children with acute liver failure like presentation. So they were given steroids either alone. 11 patients received steroids alone, whereas 37 patients received steroids along with azathioprine and or MMF. And we can see here 75% responded in terms of survival with natal liver by day 90, whereas 25% were non-responders. There were 9 deaths and 3 liver transplantation. So we looked up what were the predictors of response, and we found that Surfasa score at 72 hours, so which is a composite score based on change in bilirubin and change in INR at 72 hours. So this was predictive of poor outcome, and also advanced hepatic encephalopathy, grade 3-4 encephalopathy if the patient is already ventilated. So these were the predictors of poor outcome. So we can see here in this Kaplan-Meier curve, so this was also one of the predictor that when we gave combined immunosuppression in the form of steroids along with azathioprine or MMF, so they had almost 90% survival with an ALF presentation of autoimmune hepatitis, whereas when steroids alone were used, hardly 15% survived. And also again Surfasa score we can see here. So if the Surfasa score at 72 hours was less than -2.3, so there was a very good outcome, but when it was more than equal to -2.3, so there was poor outcome. So what about portal hypertension? So just one slide. 150 pediatric autoimmune hepatitis. This was the data collected by Sanjeevni for her thesis and also by Aditya and Anmol. So 150 pediatric autoimmune hepatitis, so 113 had esophageal varices, 11 had gastric varices. So overall 31% had varices which required treatment. Variceal bleed was present in just 9% of these patients, and we can see that median platelet count was 120 and median splenic Z score was 2.67. What about, so this is the last scenario of hepatocellular carcinoma, so which is a rare entity in pediatric autoimmune hepatitis, whereas in adults, so this is seen in up to 3.06 patients with an incidence of 3.06 per 1,000 patient years. So there is a single case report from Poland which we found in HCC cohort in children related to autoimmune hepatitis, and from our data, out of the 38 overlap and overall 255 autoimmune liver disease patients, only one child developed SCC with an incidence around 1.7 per 1,000 person years. So this was a child, 9-year-old male, presented with jaundice, elevated transaminases. So he had hepatitic presentation as well as biliary changes on MRCP. So he was started on immunosuppression, and immunosuppression was changed to MMF, but he had persistently high inflammatory activity, high IgG. So he stopped medication in between and then came to us with very high alpha fetoprotein. So CT was done which showed a lesion. So we can see here the lesion which was arterially enhancing and with washout in the portal venous phase. So this was a typical HCC, And so, so transplant team opinion was also taken, intervention radiology opinion was taken. So this was downstage. So transarterial chemoembolization was done, and we can see here. So there was lipoidal images in the second panel. So the SCC was downstaged, and the family was advised for liver transplantation, but subsequently they refused, and patient succumbed in next 1 year. So finally, about the consensus, which was published last year. So we were the writing team of 4 members, and there were 57 experts from the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition. There were 4 international experts, 1 from King's, Milwaukee, Boston and Singapore. And in this consensus, there were 4 adult hepatologists, including Sir, and 1 hepatopathologist. So these are some of the pictures of the consensus which was done last year in February 2025. So this was the process of the consensus. So the writing team started with this process in October 2024. We take approval from our society, and we defined the issues and questions by extensive literature review from October till December 2024. And these were circulated to expert faculty, and they were average of around 4 to 5 exchanges on PPTs, Word documents, via emails. And then we had the consensus with open discussion, contentious issues were discussed, agreements were noted, and finally the consensus was circulated and approved by individual faculty, and this was published in Hepatology International last year. So what lessons we learned from the consensus? That this was the based on evidence-based study. So this was, and so which proposed the diagnosis, treatment and monitoring of pediatric autoimmune hepatitis, and it covered all the different special scenarios like withdrawal, seronegative hepatitis, autoimmune overlap, difficult to treat AIH, and autoimmune acute liver failure, and simplified algorithmic approaches were proposed. And so finally, I can conclude by saying that pediatric autoimmune hepatitis has a wide spectrum of presentation. So this is one of the treatable etiology. Even in the setting of ALF, ACLF or decompensated chronic liver disease, we have shown that even with the acute ALF presentation, survival is 75%. So there are certain specific challenges related to diagnosis, difficult to treat AIH, or with the severe acute presentation. And there are certain unanswered questions related to withdrawal and also to pathogenesis. What is the role of gut microbiota in the pathogenesis and response to treatment, and also also about recompensation. Thank you.